Ladies and gentlemen, dear colleagues, welcome to this press conference to present to you the new plan for screening of COVID-19 in Quebec. The National Director of Public Health, Dr. Horacio Arruda, together with the General Director, Deputy Director for the Protection of Public Health, Dr. Yves Jalbert. Thank you, Dr. Jalbert. Ladies and gentlemen, hello. Boa tarde. I thought that a few words of Portuguese could bring a little bit of sunshine in this grayness. I am together with Dr. Yves Jalbert, who is the Director for Public Health at the Ministry of Health and Social Services. That's a position that I had right before becoming the National Director, so I'm happy to have him with us. And he's also the one who's in charge of the screening strategy for public health at the same time as all our colleagues from the network, and also the ones who take care of the diagnosis and treatment of patients affected by COVID-19. Today, we want to present to you our screening strategy with the gradual deconfinement and what we call in our jargon our populational diagnosis plan, which will allow us in terms of public health to bring a more specific diagnostic on what is happening right now. And right now, it means that we're going to be setting up a more massive screening plan in the community, in very affected regions in particular. As the Premier said yesterday, our plan includes 6 criteria that have been set out by the WHO and many organizations of public health. One, of course, is our ability to test, to investigate and isolate and intervene with cases and contacts in different situations. So that is what the public health teams have been doing since the beginning. And as of yesterday, we had 220,000 tests that were made. We test to find positive cases, identify their contacts, go up the transmission chain, and isolate the affected people to avoid the contagion of the virus. That is what we call the research, investigate, and contain approach. In the past few weeks, we concentrated on a lot of healthcare environments. That's also where the problems were. We tested a lot in CHSLDs and hospitals, patients as well as staff, and we're going to continue that because that has to be an approach that we follow. And it's been very good in terms of efficiency, because when you test in a population where there's not a lot of case, there are very low positivity rates. That means that if you had 0 to 5%, it means that the test is not targeting the correct population. But for a good bit now, we've been in between 15, 16, 17%. That means that the tests have been used on the correct population. Right now, we're doing 6,000 tests per day, and I want to bring a clarification. There are people who are tested twice, so it explains that the number of tested people can sometimes not correspond to the number of tests that were conducted, because in certain situations we have to test people twice, either to know whether people have become negative or whether they there's particular indications. Now, for the gradual deconfinement, we have a very aggressive plan that started this morning, a testing plan that started in Montreal, on the northeastern part of Montreal. We are going to be increasing the quantity of tasks that are done each day a lot. We are going to go to ramp it up as of today with the objective of conducting 14,000 tests by the end of next week, and to maintain that flow over the next few weeks. We have a reserve, a capacity of 7,000 tests per day to continue testing hospitalized patients, the residents in healthcare environments, the healthcare staff, people in RPAs or other elderly residents. And for the deconfinement, we have a reserve capacity of 6,000 tests for people who are symptomatic within the general population. And of course, we're going to be paying specific attention to the places where we are opening, for example, daycare centers, schools, plants, construction, as first respondents of public safety like firefighters, police officers, and other workers, essential workers. We're going to keep a reserve of about 1,000 tests to quickly act in case there's a particular outbreak in a certain environment or any other specific situation. It is important to note that the breakdown of tests regionally is going to be done not with the quantity of population, but a lot more together with the epidemiology of each region. For example, there will be tests for the community in colder regions, but they're going to have pro rata fewer tests than in hot zones, because that is where the circulation is being done, and that is where we're going to have a positivity rate that is going to be adequate. And of course, that ratio is going to be recalculated regularly by looking at the epidemiology that will be evolving in the Montreal metropolitan area, but other regions as well. What is very clear and very important, and you need to know, is that if we test more, we're going to find more positive cases. That is what we wish. In fact, you will see an increase in the number of cases, which is not necessarily going to be due, or it could be due to increased transmission, but it also could simply be due to the fact that we'll be testing more as such. The more we test, the more we find. The less we test, the less we find. Because there are people in population who are not necessarily diagnosed. We want to find positive cases. We want to investigate around those cases to go up the transmission chain and isolate the people who are susceptible of transmitting the virus. By effectuating close to 100,000 tests per week, with all of that in terms of, challenges in terms of handling in labs and epidemiological study and staffing, this will never have seen before. Will never be perfect as of the first few days. That's clear, because there will be, a machine that we have to set up, and delays perhaps in the transmission of information. But we are going to have to adjust ourselves constantly, and we are going to be adjusting ourselves according to the discussions that we will have with different organizations and public health sectors. Before giving the mic over to Dr. Jalbert, we'll explain to you more in detail which groups are going to be targeted and what the modalities will be. I want to come back on the statistics that we'll give you every day. We are going to make a break today because we are making the revision of the month of April. It's a little bit like a store that closes one day to go through the inventory, to readjust what I would call the numbers. So we're going to be doing that on the first of every month. And what that means is that we want to conduct that revision to have the most valid and specific data possible. In a system, for example, when we give you the deaths, we're going to give that we give you every day, there will be the number of cases that were entered the evening before. If we told you, yesterday we had 45 deaths, very often these are deaths, not necessarily the totality of the deaths of the day. Some of them would be entered the following day or even another day before, but some were a few days before. So it doesn't change the total number of deaths, but it can change the curve of deaths, because a death that is reported one day but that didn't take place on that day, it could have happened 4 or 5 days earlier. For example, like today, what I'm trying to tell you, for mandatory, declaration diseases at the end of the month of March, we're waiting 3 months to wait for the new cases that could appear later, revalidate the cases, those that were confirmed, non-mandatory, or not confirmed. So the official report has numbers that are different than the accumulated numbers, the ones that get accumulated on a daily basis. So what that means, basically, is we'll be doing this at the beginning of every month. For example, today there's 63 extra deaths, but don't get alarmed. These are not deaths that took place yesterday. These are deaths that go back to April, but that only were put in our system yesterday. And you'll see that with the chart that we'll be showing you over the past 10 days, we are at about a plateau of 85 deaths per day. It's not going down, but it's also not increasing. So what I wanted to tell you is that you will be seeing that now, as of now, every month, we will be publishing data that will be what we call the validated data for the past month. And that will bring about differences compared to what we gave you. It's important that you know this, and that's what I wanted to tell you today. So if you want in the question period later, I can give you the number of hospitalizations and the same number that we usually give you. Now I want to give the mic to Dr. Jalbert, who's going to give you a little bit more technical information on how this massive screening is going to be executed and what expectations we have toward the population. Thank you, Dr. Arruda. Hello to everyone. So for our strategy for the use of tests over the next few weeks, it has to be said, first of all, that it's going to be as of the 4th of May, so starting on Monday, that the people who have symptoms of COVID-19 will be able to call. There's a telephone line that is dedicated to that, and it will be communicated to you, will be made public. So as of Monday, people will be able to call that number And those people will be referred to a designated screening center. They're already known and set up. Or, if is necessary, an evaluation set or clinic. So we have a regional breakdown of the number of analysis that can be done in a day, and the CDDs are going to be supplying the number of available schedules in the next 24 hours. So people who call, we expect them that they have an appointment within the 24 hours. That is really going to give very quick access to the test, and the results are going to be communicated as they are now by a nurse or doctor. For requests that could not, or people who are not able to find an appointment within 24 hours, they may be referred to a CDE. And those are together with public health. Dr. Jalbert, so that we don't get confused, CDD and CDE and CDD are things that people might not understand. Designated Screening Center for CDD and Evaluation Designated Center for CDE. Sorry. One screens and one evaluates. So the CDEs, or the evaluation centers, do evaluate, whereas the screening ones, the CDDs, are the ones to just get screened. So the CDEs, the evaluation centers that will get people for whom we cannot give an appointment within 24 hours in a screening center, are going to have an evaluation. And then the evaluation centers are going to enter in contact with public health authorities to be able to do a follow-up through the management of cases and outbreaks or investigations, etc., that can be done in the evaluation centers. And those centers will also take care of doing the declaration of mandatory declaration to public health authorities. So whether it be in CDDs or CDEs, they are be advised for isolation and management of contacts. All that advice will be given to the patients. Now, we have, together with all that, we've made a revision of the priorities of screening. We had a list of priorities that we have now converted into a grouping list, and the priorities are going to be determined according to what we set up operationally speaking. So we're talking about groups, and I'll summarize now because it's pretty technical, but there is group 1, that are the symptomatic patients hospitalized who need regular care in a hospital care setting. So this is to capture the people who could come in, who could bring the virus into the hospitals or are already there with the virus. The second group are healthcare professionals who have symptoms, particularly when those people where their absence could cause a breach of service, and we want to be sure of their status. The third group are the users and the staff in residences such as CHSLDs, RPAs, and RIFTFs. Now, I understand that you know those acronyms, yes? So these are places where elderly people and with chronic needs are housed. As soon as there's a new positive case that is identified in these places, we can do analysis. This is a category that already exists. Group 4, that is where we have a big change, which is going to have a lot with our ability to control the epidemic in Quebec. Group 4 are the people who are symptomatic of all communities. So that is the important point. It's a lot on those people that we are going to concentrate when we make particular effort over the next few weeks. And that includes places that we are reopening. So people, for example, who go back to school, daycare, plants, manufacturers, etc. Group 5. That also has not changed. First respondents or workers of the public healthcare system, people who supply services that are considered to be critical or essential. And finally, Group 6. The other group that has to do with public health authorities, we're talking here about contacts of confirmed cases. This is a very important strategy if we wish to intervene on our epidemic situation in Quebec. That is beyond getting the people who are symptomatic and of testing them. We also have to be interested in their close contacts and go up the transmission chains. there might also be in that category interventions that target the description of a situation in certain environments. For example, we could arrive in a company and sample a certain percentage of the employees in that particular company to really have a description of the epidemiology in that environment. All of this will be managed through public health authorities. So, for the upcoming steps for the deployment of the strategy, we are, of course, going to be proceeding to the diagnosis capacity regionally in the screening centers, and we are going to have new screening methods as well, or sampling periods, to reduce the needs in material and human resources both. We're thinking, for example, of using expectoration samples rather than swab samples, which would really simplify the sampling and which will remove the problem of buying the swabs, because we know that they're very much under demand in the planet, and it's not always easy to get them. So this is a new approach that is well adapted to the present context of deconfinement, and that we're setting up. We're going back to massive screening that is going to allow us to better measure the community transmission. We have the ability to increase the number of tests right now, and we want to use that wisely. And we also have to, we really wish to detect any possible outbreak that could happen in one of our deconfined areas, so schools or companies. So we are following all of that very closely, and I thank you. Are you ready now to take questions in French? Yes, so we will be starting with Mathieu Dion of Radio-Canada. What is the average efficacy rate of those tests, and how much do you evaluate the risk of false negatives? It depends on the quality of test, etc. The test that we use in Quebec, it has to be said, is a test that was made with the lab method of public health, which is a test. First, there's no test that is 100% perfect, so that has to be known. It always depends on what kind of population we apply it. That is to say that if we apply it to a population where there's almost no cases, we're going to have false positives, and we may have false negatives as well. So the test that we have first, it's difficult. We can't calculate completely because it would we would require a gold standard, like the perfect test, which does not exist right now. What we do know is that the test that we use here is very sensitive in the sense that it detects with very few viral particles. So it can detect the virus. It's through the PCR method, so it can detect a very low quantity of virus. But we note that the tests that are promoted by companies that want to do PCRs and where the results of which are very quick, it's 100 times less sensitive. You need 100 times more particles for it to be positive. So commercial tests tend to be a little bit less sensitive than the ones that we use here, according to the information that the public health laboratories of Quebec have obtained, even from companies themselves, in the quantities of virus that they can detect. So it's always possible, but it's also possible that if we test on symptomatic patients who have a clinical history, we have a predictive value which is positive, like the test that says that it's a positive, but it's a real positive, that value will be higher. Up until now, when we follow the positivity rates that we have had in Quebec, which are around 16%, I would tell you it's even gone up higher than that. That means that it's a test that is used in the correct populations. I'd love to be able to tell you that there's this percentage that are false negatives and all that. First, it depends on the test. First. Second, it depends also in what population it was used. Because a test, we always have the impression because you do it, it's positive or it's negative and it's perfect. But no, there is also an influence on what population you've used it with. If you have a lot of cases in a population, the test is going to be better. It's going to perform better if there's not a lot, because the risk of error is not as high for that. But what that means, in fact, is that yes, there are some. When people have symptoms, the probability goes down of having false negatives. Well, people are symptomatic and can go down, but there are people who are symptomatic that can also be positive because the test detects very small quantities of virus. I heard you talk about commercial tests. Is it a good idea to use them then? The Spartan test, for example, which has not even been approved or registered by Health Canada. Well, it's in our plan. If we want to increase the capacity of testing, that kind of technology is easier and quicker in terms of elements, but we will be following. When we do it, we'll do it with an analysis with what it's worth. I don't know if you know what I mean. Perhaps we're going to reserve those tests for certain kinds of patients who absolutely need a more specific diagnosis, whereas in populational masses, that kind of test could be used. But we have to wait to get the more specific data. We're talking about it a lot, and we talked about it a lot ahead of time. They're part of our plans, that one as others. But right now, what we will be doing right now, it's not that at all. When we talk about increasing to 14,000 by next Friday, we would be using the same methodology, the same kind of test that we've been using up until now.
Dr.
Arruda, there are scientists that are saying that right now in Quebec there are 250,000 people who are infected. Can we have an idea? Because when we are talking about 20,000, we know that it's not reality. But according to your curves, how many people are infected and who don't know, who have not, had the disease in a very serious way? It's a good question. I would have to go look at my calculations, but I think, of course, we have more than 20,000. There is no system right now that is able to say. Very often when you have tests, it's to see trends, etc. But we do believe that the prevalence in Quebec is at about around 3% maximum. We're talking 1 point of 10, but when we look at the other countries and the studies that were made in other countries, we think that we're more around 3, maximum 5%. Perhaps in certain subsectors where there's been more circulation, it would be over. But if we say 3% of the population, if you calculate 3% of 8 million, I'd have to make the calculation, but it must be what? 250,000? Okay, so it's about that. When you increase the test, that's what you're doing right now. The ultimate objective of doing this is to give yourselves an idea, because you've told us already, as of the moment when we are conducting tests and that people are ill, you require 14 to 21 days before you develop the disease. So as of the opening, you won't have a very specific portrait before 14 to 21 days. No, we're not going to have a specific total portrait of things, but it's clear that we're going to be following many indicators. The number of cases, but the number of cases depends a lot on the number of tests, so it does have a value, but we're going to follow if there's outbreaks. For example, in the schools that we open, are there going to be outbreaks? A manufacturing plant that produces, I don't know, a kind of food, are there cases? Because the other thing, too, is that at the same time as we open, at the same time, we'll be doing a diagnosis in the community, but also around the outbreak points. For example, if ever in a manufacturing plant we end up with, 100 people, I don't know, and 14 are ill, well, those 14 ill people, we're going to make sure to know who they are and to investigate on each of those cases in the family, the contacts, etc., in order to be able to control the situation so that the outbreak of the company, in the company, does not go back into the community and create even more, increase the number of people who fall ill. And also, are there asymptomatic people? And as an example, if we have people who are asymptomatic and we ask the asymptomatic people in a Montreal region, for example, to show up, and, we're going to test them. The ones that are positive, we want to know what their contacts are. And we might test the contacts to know, are they ill? Do they have symptoms? To be able to confine them for 14 days to prevent transmission. So it is a series of interventions such as these that will allow us at once to document the deconfinement that we made, what it generates around that environment, and also sometimes to test beforehand to see what the status is as such, as we will be doing in CHSLDs. As soon as there's a case, we test the other ones to see what the status is. So that gives us a better diagnosis. But of course, we can't test everybody. And we're starting with symptomatic people because that is where we have the biggest chance of finding somebody who is positive, of identifying the contacts as such, and testing those people who are probably going to be at higher risk of having been contaminated and asymptomatic than somebody who's just an asymptomatic person in the population at large. It's a question of a probability and using the resources to do the diagnosis. You talked about more than doubling, so from 6 to 14,000. This week you even said going up to $20,000, $30,000. Where did you find the material and the staff to not only do the test, but to analyze them, do follow-up, and make sure that these people are isolated? Well, first I talked to you about, now we're talking about the 14,000, right? for next Friday. So that we do have the capacity right now to do that. When I talked about the other quantities, the 20,000, whatever, we're talking in a few weeks' time. And by then there will be new technologies and other kinds of approaches that could be used according to the estimates that we have. And, I've always said it. You're going to get back to me and say, Mr. Arruda, on the 1st of May, you said this, and you said in 6 weeks, and now it's been 6 weeks, and we still don't have it. It's going to depend on the constraints that we have. But we didn't talk to you about screening scenarios earlier on because there were too many unknowns. Now we're talking to you about it because we think that it's pretty strong, but I'm giving you a far-off perspective with what we're hearing. But if the tests were told, that is not registered by Health Canada because it's not good enough quality, well, that will change our scenarios. We have other alternatives, and we're keeping a close eye on that. But I can tell you that with the 14,000 tests that we're doing right now, we do have more than others, and even in the rest of Canada, everybody together. But we are doing it. And as Dr. Jalbert was saying, the new expectorant approaches, it means to spit, basically, to expectorate. People have to know how to spit. Some people can't spit. But for those who prefer spitting rather than having a swab, put up their noses, if it works and it's valid, so much the better. It's going to be even less complicated. We ask people to spit, they spit, and we need to send it to the lab. We don't need a nurse with a swab. With the deconfinement and more tests, are you now at recommending wearing homemade masks in the students going back to school? Listen, as far as wearing homemade masks is concerned, people have always thought that I was against. I'm not against it. And I mean, you could all have one here and you would still be my friends. I'm not against wearing homemade masks. What I've always said is that I don't want that to replace other elements because it makes people feel that they're being protected with a homemade mask. What I would say is school is going to start up again very differently. It's not going to be the same classrooms as before. I know that people have a hard time understanding this because they see school and they see children all arrive together in the hallway, all crammed together. You have to understand that it's not because one is less than 2 meters away, below 15 minutes, that automatically there's been a contamination. But if the children want to wear one and they tolerate it and they don't, and they still wash their hands and don't touch their faces, I can't say that I'm against it, but children, I find a little bit alarming, the mask. And in daycare, however, the educators, because they have much more frequent contacts, they will have the mask. The teachers, it's also a question of distancing. But I can tell you one thing. Somebody who wears a mask, first, they do it to protect others, not to protect themselves. But I wish to repeat again, and I know that I look like a psychotic schizophrenic when I talk about hand washing, but it's been years that we've been trying to show, even in hospitals, to people how to wash their hands. And even people with the best material in the world, sometimes they do errors because it's not natural. And when you're protected, with a screen and you have your gown and all that, you don't have the impression that you're contaminating yourself, but you are. It's a challenge to add that. But I mean, if they want to wear a mask, especially now that there's such pretty ones coming out, there's a market that is being developed. I mean, at some point I'm going to have to coordinate my ties with my masks. But anyway, I don't want to make fun of the mask. That's not it at all. But I'm just saying, if people want to wear it, fine. I think that in the metropolitan area, people who take public transportation, etc., a face covering is going to become an element of respiratory etiquette, if you will, rather than, coughing in your elbow, you'll be wearing a mask. It could be adequate. Mr. Arruda, Dr. Jalbert, a month ago, almost to the day, I had started talking to you about randomized or random tests. I'd ask you the question, now you're saying we are starting with symptomatic people because we have better chances of finding them. Doesn't seem a bit antinomic when, people, it's a good idea that they have it. We think that they might have it, therefore we're going to test them. Whereas if we want to know the quantity of asymptomatic people who have it, well, it seems to me that we should address ourselves to them first. Why don't we do more random tests? Because you almost didn't talk about it. You said maybe in certain companies. Why don't we target areas? We talked about Montreal North, for example, where there was an important problem here. Why don't we talk about certain neighborhoods and we don't test massively? In Montreal North, there will be tests because there's a specific situation. There's an outbreak, so there will be tests. First, just to tell you, when you case asymptomatic cases or symptomatic cases, you will have asymptomatic cases. You know, if we had an infinite testing capacity, we could test every Quebecers and then we'd have to repeat them because right now, if you have a test in an asymptomatic person in the Bas-Saint-Laurent region, you'll have 98% of chances that it would be negative. Do you understand? That's the question. And a part of the answers are going to come with the seroepidemiological studies that will be done, which have not been done yet. But because it's true, you could tell me, well, we already know. The classic syndromes of people who have coughed and they look like they have a cold and they lost their sense of smell, there's not that many. A lot of people on our lower symptomology. So they're almost asymptomatic. Our test on those people is going to also help us control the cases of contacts and the transmission. But I understand what you're saying, but we're thinking about the best use of testing right now. But, you know, as to know how many people have really had or got the disease and weren't tested is going to be when we do seroepidemiological studies. Because on top of that, if you test people, they might get tested and then they'll be negative and could only be positive 2 days later. So we have to do with what we have. But in schools, because there's a big concern in terms of possibilities of cases that could be transmitted either to the teachers or to the children who are then going to transmit it within their family unit. How are you going to be testing and how many tests specific for schools will be given? It will depend. Maybe you can complete, Yves, because you're the ones who know more about the scenarios, but there's a proportion that is reserved for those elements and for the Director of Public Health, depending on the situation. But it is clear. Let's say that there's a case in a teacher. Let's say that there's teachers or children who got the illness and nobody got realized. But then there's a teacher who realizes one morning that they can't smell anymore and can't taste anymore. Then we'll say there's a case. Now we'll do the investigation around that teacher. We're going to go test their colleagues and the children, and we'll get the portrait of that situation. Thank goodness the teacher would be in good health and will leave the school because we don't want them to contaminate any other persons, and we'll investigate their family if ever there were any contacts, etc. So it will be done through the cases that will emerge, and depending on the region where there's availability to test when there's no circulation, the directors might decide that rather than leaving this many tests per day, I don't know, 100 to 300 tests per day not being used, we're going to say, well, test randomly. It's a little bit like that. It's an analysis that will be done regionally. And the distribution of tests as well, Let's imagine that, and I'm just saying this, off the top of my head, Mauricie, Centre du Québec becomes a hotspot, like Montreal, or starts to become a hotspot. Well, there are tests that will be sent back more to that area to pose the right diagnosis. So it's always through a sampling element with a detected probability. It's never to know the total quantity. It's to see the trends. And I would add that with all that, we're of course going to test people who are symptomatic in a more accentuated way, and we will give ourselves the capacity in public health to be able to follow. I was talking about mandatory declaration diseases, so there's information that are delivered to public health. We'll have a structure to make sure to quickly capture information on an environment where there would be many infected cases. So quickly to see whether there's a specific problem with the schools, with the daycares, with working areas, to be able to act very quickly. And beyond that, if we have any fears in certain environments, specific ones, then we'll be able to do the analysis or blind studies. That is, we'll take a proportion of the people in that area and offer them the test to give themselves an image of the circulation of the virus in those areas. We have to understand that with the tests that we have right now, if you arrive the day before the person has enough virus in their bodies for our test to become positive, well, you'll have a negative that doesn't mean much. And the validity won't last long. So the test right now is not the best for that kind of intervention. But we will do it to make sure that we quickly capture the areas that could be, a situation with more delicate situations to manage. Also, you talked about staff and all that. We implement a new platform that is called Equinox that allows us to manage case contacts right now, and it's working pretty well. And also, it manages the cases. I think it will be this week that it will be implemented, no, next week. And so it will automate a lot of the operations. People will receive an investigative survey per email, which will avoid that a nurse take a half hour to talk to the patient. So we give ourselves technological tools and a greater inquiry capacity as well. Hello. I would like to know, do we have the capacity in terms of equipment and resources to do random tests and more systematic tests in schools before back to school? If we had wanted to do it, could we have? Well, we put a number of 1,000 analyses per day. That's a lot that we could conduct under the category of case contacts and those interventions in specific areas. But even then, we agree that if we wanted to capture all students, all the teachers, it would be difficult, and we would have to repeat it as well, because as we were saying, the validity of the test is not good in the long term. So we have that, concern of getting the answer to the question that you're asking. Can we protect those people? But we need a strategy that will allow us to reach it with our testing capacity right now. And in the recommendation to groups and the choices that were made, because we can't also leave aside a clinic and tell people at the clinic, we don't need you anymore. We're going to take everything to do the screening. It was done with the experts to tell us what is the best balance, taking into account the resource that we have to be able to answer those questions. Earlier on, you said that we have an average of about 85 deaths per day, that were in a plateau, that it wasn't going down, but it also wasn't increasing. Starting with how many deaths per day in increase would you consider postponing the reopening of schools in Montreal? The reopening of schools or the reopening of any area where deconfinement is associated with analysis of many variables, the 6 conditions that the WHO talked about, the number of deaths, what is clear is at first, the number of cases cannot be the factor, especially when we screen more, because then you end up with more cases. However, if you see that the hospitalizations are increasing, that the emergency wards, that we can't reopen intensive care anymore in other places. If there's an overflow and we can see that there's a re-increase in that, then we could step back in terms of deconfinement. And Yves, perhaps, it's a series of factors. It's not just one number, and it's not just because you're at 100 one day and that yesterday we're at 95 that it means that we are increasing. We really have to look at the trend depending on the days, and we also have to see the RO, the number that we look at, the reproduction of the number of cases and of days necessary to double. A lot of analyses are being done right now in Montreal. There will be a lot over the weekend, and that is data that we'll be able to take into account when we make decisions. I would like us to come back on the daily numbers, if you will. We went over that quickly. What are the numbers? And should we understand that there will be a reconsideration of the daily presentation of those elements? No, that's not it. I'm going to try to be clear. Just to tell you that at the end of a certain period of time, we'll be giving the daily numbers. You're going to get them. We're not here to hide anything from you. But when we give daily numbers and we say there's this many deaths, I'll give you an example. If I look at yesterday's report, 163 deaths that we got yesterday. But in fact, out of the 163, those are the ones that were declared yesterday, but they did not take place yesterday. Yesterday there were 22 more There were 22. No. The 163 that were declared yesterday, not the declaration date. The date of the death, one was the 3rd of April, one was the 17th, 2 on the 18th, 1 the 20th, 1 the 21st, 4 the 22nd, 4 the 23rd, 3 the 24th, 10 on the 25th, 4 on the 26th, 16 on the 27th, 33 on the 28th, 29 on the 60th, and then 22 on the 30th. Perhaps it's only 5 days after that the number of 22 that we'll have and 30 is going to become 80-some. Because what we have right now when we look at the data, because on a daily basis, we have the cases that are declared to us, but it's not the cases that represent the specific death date. For all sorts of reasons, delays and inquiries. Let's take, for example, the patient dies. In theory, we have 24 hours to declare the death. Okay, so we said it, but the SP3 form that has to be sent to public health to take into account the information wasn't sent. By the time they get it, if they weren't able on that day because they'd arrived late in the system or whatever and they weren't able to enter it, there's another day of delay. So, in, mandatory reporting diseases every year, it's the same thing, and now it's on a daily basis. Usually we, report cases weekly, never daily. The daily numbers are corrected over time. So at the end of the month, we're going to be looking at all that, and the real curve that we had every day is going to be corrected. That is, the 163 deaths that we have today, they're going to be placed in the right day. That is what we call validated check reports. That's what I want you to understand. And you're going to see, we want to distribute a curve. I don't know if you have, we distributed one. I don't know if you have it in front of you. And you can see that the last day, it's not written 163 cases because some were placed on the 3rd of April, the 17th of April. So it's just to tell you, to make you understand that we're going to be making reports every month that will have corrected what took place over the past month to replace the numbers. But we wish to have the incidence, that is the number of deaths per day, and not the number of deaths declared that day. Am I clear? I thought you were going to tell me about the hospitalization numbers as well. Yeah, I'll be giving you that. So the 30th of April, 2020, I'll give you the numbers. 28,600, the interpreter missed a number. So that's 1,110 new cases. We are at a cumulative of 2,020 deaths. As of yesterday, or the day before, the number of deaths that were reported to us, not that took place yesterday, 163 new deaths. That's what I was explaining to you. So it's 163 new deaths. Some of them go back to the 3rd of April, up until now. 6,700 people have recovered. 1,716 hospitalizations, so that's an extra 31. 218 in ICU, that's an extra 4. 6,166 confirmed cases in healthcare workers. That's 302. My other question has to do with the screening. There are experts to whom we spoke earlier this week who were saying that one of the criteria of the WHO, as you said, is a good screening capacity. But they were saying that before deconfining, you had to start by increasing the screening in a significant way and wait at least a week before deconfining if the operation that was done during that week. Now we're deconfining the retail stores with outside door Monday. Why did we not give ourselves that delay to proceed to that new strategy and that increase of tests? I will say now we are proposing a diagnosis, and we will see. As far as the dates, those dates were announced in terms of scenarios. I'm not announcing anything to you today, and I can't pretend to, we're going to see what the Montreal numbers are. If the conditions are not there to be able to open, they won't be. If they are there, if we do meet them, then we'll do it. Just so that it's clear, Dr. Arruda, the deconfinement on the 4th of May corresponds to a very small proportion of sectors. and which in other places weren't even closed, actually. So it's a deconfinement at 50% of the capacity, as I was saying, for the time being. There is no decision made to not do so. If it changes, we'll see. But what I wanted to say is that basically these are sectors that were not closed elsewhere. In places, for example, like Ontario, they weren't closed. So we are doing it prudently, and we're going to keep a very close eye on it. Thank you.
Bonjour.
You talked about the list of priorities for the test. Mr. Arruda, you really gave a very concrete example of a professor who would be infected. But I mean, teachers are very far in that list of priorities as far as screening tests are concerned. So every time that there is a teacher with symptoms, will they be tested? And if they test positive, what happens? Do we close down the school? Are teachers informed right away that the teacher tested positive? Well, first, when you say that the teachers are down on the list, that's not how we see it. The environments that will reopen are going to be monitored to see if there are any outbreaks. And when we talk about outbreaks, usually we talk of two cases. As soon as a teacher is tested or has symptoms, first, if they have symptoms, we don't want them to show up to work, It's going to be, like in schools, usually there's somebody else who can come and replace them. So if they have symptoms, we'll test them. And if they really are positive, we're going to intervene in the schools and identify them, what the class is, who the teachers are, with whom that teacher came into contact, any period where there were not a non-respect of the 2-meter distance. So we'll investigate in the school environment, but also in their family environment at home to take the situation in hand. Now, depending on what will happen, we will see what we can do. If there's any other children who are tested positive, we'll be taking them in hand, and making investigations around each case. Now, the question of whether the school is going to close, the education sector is going to decide. If we think that this is a transmission area because everybody's together, we'll see. A decision will be made in a case-by-case scenario. A question we've had for a while. You said there are certain people who are at risk, for example, parents who are over 60 years of age or who have chronic diseases, who are immunosuppressed. So you told them to not send their children to school or daycare for this period until the end of the school year. But those people will also have the same conditions in September, where all schools will be reopened. So what will happen for those children? Will they be able to go to school? That is a situation that will be reevaluated depending on where we're at with community transmission, etc. And also on the basis, because, this is quite a question that has a lot of controversy in the literature. Are children, can they be asymptomatic? We believe so, that they can have much less serious syndromes, thank goodness, but are they great transmitters in families or not? We'll get more information on that based on the Quebec experience as well as what is happening in other countries. Because some people say, unlike the flu, where children are virus bombs who replicate and replicate, it's like a gastroenteritis. You have children in a daycare, etc. But apparently it's not that in the case of COVID-19, or maybe it is as well. So it's that kind of element that will allow us to make better decisions to see what we'll do in the fall. Hello. Just to understand you correctly, so the massive strategy that is being set up, wouldn't it have been possible to set it up at the beginning of the crisis, at the end of March? Wouldn't it not have been useful or necessary? Yeah, go ahead, because I'm talking a lot, and, you haven't spoken much. I'm sure that they want to hear you. Well, at the beginning of this entire situation, we had to respond to a virus that we didn't know much. It was quite new. We set up a lab capacity that is pretty important. It's important to mention it. And we had to observe a little bit what the return was on all that. And what we realized very quickly is that there was more demand than there was capacity. and a demand that was very much associated to clinical issues for which we did not yet have all the information. We did not know at the time, and we don't know everything yet, but we didn't know at the time how people react to this virus. So the mortality rate, we had no idea what it was at the beginning. So we ended up very quickly in a situation where a lot of people wanted to have the test and with a capacity that was not enough. So we ended up at a certain point with a delay in the delivery of results in the labs. So it would have been counterproductive then to add on that an intervention to go get more people, because if the results only arrives a week after, we, of course, understand that there's a lot less value to it after. That is a situation that we no longer have. So now we have a residential capacity of lab analysis, and that is what we are basing ourselves on. And now, if you will allow me, the purpose of this operation now, it's to decrease the transmission rate, the R0. So, or is it to keep it under control, or is it to decrease it? Well, first, it's to get to know it better, because it is calculated on the number of cases and the reproduction. Second, it is, in fact, controlling the situation as such, and also to allow us to do what we call identify. It's to have a populational diagnosis, basically. There are people who have symptoms, they come to the emergency ward, the doctor is going to be able to do the test or not. But I would like to know, the patients. It's many patients. I'll give you an example. What's happening in Montreal now, right now, as such? What is the dynamic in terms of transmission? What are the characteristics of the people who are there? Could I have hypotheses of how it happened? First, control it as much as possible as well, so that it doesn't go elsewhere, etc. So that's what it is. It's a message that is there. And when we deconfine, we also wish to see what is the effect of the deconfinement. If I end up, let's say you open, a small business with doors outside. If I end up with important outbreaks, for example, the clientele of a certain place is a common point. We realized that in such and such a store, there were 14 cases. We tested people, and there was one person who was symptomatic, and then we try to have the list of people. There we'll be able to say, okay, here, there's an issue. Of course we take measures. We're not going to reopen the same way. Small stores are going to have to maintain distancing. That is what has to be understood as well. We want to test to see where things are not working.
Question d'un média qui n'est pas représenté ici à la tribune de la presse. La question nous vient d'Étienne Phoenix, Bell Media. Considérant que la COVID-19...
Considering that COVID-19 is not a pulmonary disease, apparently, but a blood disease, wouldn't it be better to have a blood test to detect the disease? The nose test gives a lot of false negatives, which complicates the displacement of patients between hospitals. Well, listen, the virus, for sure, it goes in probably through the respiratory tract and invades that area, because that is where it's replicated at the beginning. That is why we go get it there. It does, in fact, go into the bloodstream, but the detection of the virus through PCR in the respiratory tract seems to be the best thing, because before the virus gets to the blood and infects everything, of course, in certain people, it's going to be vascular diseases that it leads to, but this disease has an affinity with the lungs and pulmonary secretions. So once we see that the best test to do the diagnosis is something else, well, we'll use it. But right now, it's not the case for what we call, tests to check whether people have recent antibodies or so. That's not even something that the seroepidemiological studies are not even really, correct on that. So the standard to do what we call a correct screening for the research of the virus through the secretory tract through PCR. And PCR, what does that refer to? Polymerase chain reaction. It's PCR is a polymerase chain reaction. So you use an enzyme to go identify a specific part of the virus, and you can say that it's positive. It's a way of testing the genetic of the virus. When you have that, it's very specific, but when you have the microbiologists would say that maybe not 100% because we have families or cousins of viruses that react the same way. But together we identify if we take a secretion close to the coronavirus and you put the test and you analyze it, it reacts with the specific DNA of the virus. Thank you for that clarification. We're now going to go to English questions.
Good afternoon to both of you. Dr. Jalbert, you said that in March, the situation was overwhelming. You had too many demands, not enough capacity. Now, we are opening. We're opening the gates gradually. To get to the bottom of this, testing, contact tracing, but then you have to know what's the proportion of people that are infected but not showing symptoms. I have no idea how you're going to get to the bottom of this with the people that are not presenting symptoms with this plan.
Well, for the first part of your question, we now have the capacity, which we didn't have a few weeks ago, okay? So that's not a problem, and it's this capacity that we want to use for this new approach. For the question of the person who carry the virus while they're not showing any specific symptoms, we know this is something that exists. We know it is a real phenomenon. What we don't know is the exact importance of this, okay? So we have a lot of demonstration that people who have absolutely no symptoms can carry the virus and transmit it as well. But what importance this had so far in our global pandemics is still to be demonstrated, okay? Obviously, this is quite interesting for us to know what happens on this side. And it's something that we would like to clarify with these new blood tests that are supposed to be available in a few weeks. So we expect to have serological tests done among, well, we will define a strategy to find some people to be tested. And this may provide some clue about the proportion of people who have been infected without showing any symptoms.
And that's really the seroepidemiologic studies with blood that will tell us what was the proportion of Quebecers who are being infected and which proportion probably that will have no symptoms. It's not going to be to I would say, test strategy of tests.
But Dr. Arruda, as we are opening gradually, but Quebec on pause, why Quebecers should feel reassured with this new screening plan if you don't have a clue about this untangible proportion of people who do have COVID-19 without symptoms? It's still fuzzy. It's still not clear.
But whole coronavirus is a fuzzy thing, and probably we'll know things that we don't know today. But no one can wait for that before deconfining. So we are having strategies to do it in the right way, and also to make sure that when we open, we measure, we open, we measure, we open, we measure. And if things are going okay, we continue to open. If things are going bad, we stop. But we will be making the diagnosis of each step we're going to go through.
Samuel Pouliot, CTV News.
Hi, Dr. Arruda. Montreal North is a hotspot right now in Quebec. How many tests do you hope to perform in Montreal North? And do you think it would be useful and helpful to record and collect race information like they do in Toronto?
Could you repeat just the last part?
Do you think it would be helpful to record and collect race information, like about communities? They do that in Toronto.
this is part of the characteristics of the person that is going to be accumulated. Yes, it's going to be
collected.
Yes, it is. And I just want to say also that Montreal is going to work with the association of those communities to explain the why and collaborate. And so it's going to be a very proactive, I would say, approach. We're going to invite people to come, but we will also be working because of cultural aspects with the I would say, the organismes communautaires or the groups from the community, based on the community, to be partners to this screening there. Yeah, we think it's around, if I'm aware, it's going to be around 3,000 cases, tests done in the next days.
Thank you. The next question is from Phil Autier, Montreal Gazette. A study today by the Université de Montréal estimates there's are more than 2,065 COVID-19 cases in Quebec. What is your response to this study?
In
Not
fact,
sure of the number, sorry. So 265,000.
Yes, in fact, it's related to what we think is the proportion of people who have been infected in other places like here. We thought it would be till 15%, but in fact, actually, we think because of the containment we made and the stopping in Quebec, it will be almost over 3%. Or 3%, or even less than that. And if we extrapolate this 3% around the, I would say, 8 million persons, that's around those numbers.
Thank you. The second question. Please describe how contract tracking is going in Quebec. How many people are currently doing it now, and how many will you need as the deconfinement starts? Please tell us exact numbers.
Okay. I could not, I don't have them, but we've got the capacity to do the job we have now. And we want to, I would say, even double, I would say, in the next days and weeks, the capacity. We have been offers from different parts, universities that are going to make us available. We're going to also work with firms who are doing polls, phone polls. We are having new technology helping the facts. So we are aware that will need more people. I would say a ground estimate of more 50% than what we have now, because also those people are working every day since, I would say, more than 100 days, and we need also to make sure that they are getting some rest, and at the same time we want to make sure that the people will come to help us, will have the minimum, I would say, formation program to be able to work. But we already had developed those, I would say, training programs for the ones who are going to get helping us to do public health investigations.
Thank you. Two last questions from Raquel Fletcher, Global News. Now that schools are going back, do you have any concerns about summer camps operating? This is a big deal for parents. We would like to hear your views.
I think the issue of summer camps is important. I think that there could be opening like others situation, but in respect with some conditions. I know that dormitories are always a problem, I would say, in different outbreaks, even in the military things. So I think if they open, they will be opening in a perspective of, I would say, keeping distancing.
Pouvez-vous répéter en français votre réponse?
Yes, for the summer camps, I think that they will be able to reopen. However, it will have to be reopened in a way that is different from what we're used to. You know, like the sleeping quarters in the army or in the cadets or elsewhere, they've always been transmission sites that have been very significant in the case of infectious diseases. So I think that it will be reopening, but with specific conditions. Summer camps as well. So we'll have to make sure that we maintain the 2-meter distance from the people who are healthy. Thank goodness, usually, these camps are, the workers are young people. So we'll see how it can be done, but I don't think that it'll be able to be, 400 people in dormitories with sleeping bags stuck all together, crammed in a sugar bush or a dormitory room such as a gym.
last question from Global News. When it comes to testing essential service workers like orderlies and medical staff, why can't everyone be tested regularly?
Because we need to have a reason to test people, and I understand that people are giving to the test a power that is not there. Sometimes if you have no symptoms, you can be tested and it can be positive, but it can be negative, and it doesn't mean that you're not infected. So we combine different types of strategy to do the best for the person. I don't know, Yves, if you want to add something in English.
And in addition of that, we ask every healthcare workers, for one example, to behave as if they were infected, keeping distances, wearing a mask. So we think this lowers the risk pretty much.
Thank you very much. So that's it. Dr. Arruda, Dr. Jalbert, merci pour votre disponibilité.
Thank you for your availability, doctors, and we wish you all an excellent weekend, and to you as well. Yes, seriously, I hope that the weather is nice. A little bit of sunshine is going to be good for us, because I admit to you that today it's been a great day. Take advantage of it yourself. Thank you.